Hello.
Shyam, your screen is gone. Huh?
Yeah,
Shyam?
I think he lost connection.
Oh my God.
Not joined back now yet?
Yeah, I'll just
No,
call
no.
him and see what's happening.
Yeah, sure.
Yeah,
He's
it's
back.
Joined back. He's joined back.
Oh, yes. Yeah.
Yeah, so you described all the symptoms very well, I think. And these things are evident. But one thing which was, I think I was not able to understand. You said that she had GERD symptoms, reflux and all, and there was no history of weight loss. How would you explain that?
Yes, sir. Hello.
Yeah, you got my question?
Yes, sir. So, sir, can you just repeat it again, sir? I was some problem was there, sir.
So you described she had regurgitation and some reflux symptoms also. But then
Yes,
in
sir.
another slide, you mentioned that she had no weight loss. So
Yes,
do
sir.
you want to revisit that history
Sir,
or? Uh,
it was basically, sir, a reflux. The history she gave, sir, it was of reflux only. She never had any dysphagia or anything, sir. And it was mostly evident during the night only, sir. And it slowly progressed, but she denies any history of any weight loss. Uh, Apart from that, sir, there was no history of any chronic diarrhea or any other symptoms. Apart from that, so GERD per se, so she had problem with the she did not have any problem with the taking food, sir. It was after the taking meal she used to get those symptoms. So I think
okay.
uh, yes, sir.
Okay. And the Raynauds and the skin thickening, it started simultaneously or
So
there was a gap?
almost simultaneously. First thing she noticed was the milk discoloration, and within 3 to 4 months, only what she said, she started noticing the thickening of the skin. She was unable to pinch her skin, and the skin became quite shiny. Was the she gave her. So it was initially present on the both the hands, and slowly progressed to involve the forearm and arm as well as the face.
Okay. Okay.
From the
And
history, sorry, Avinash, continue.
no, go ahead, Nina. Yeah, please.
So from the history, can you differentiate between a primary and a secondary Raynaud's?
Yeah, ma'am. I can differentiate it.
Yes, so how would you differentiate?
So primary Raynaud's generally present just like the before age of 20 years, and it involves almost all the fingers, and it doesn't lead to any gangrene or ulceration. And yeah, and typically the triphagic phenomenon is seen in the primary Raynaud's, but secondary Raynaud's also it can be seen. And she had history of blackish discoloration of her fingertips. So that was very not, and it all started at around 35 years of age. So that
Yes.
second point also goes against primary knots. Yeah, ma'am.
Yes,
And
and
she also
again
does not have
bilateral
any
also.
history.
Usually, just a point is
Yeah, ma'am.
always that it is bilateral. Whenever it is primary Raynaud's, usually
Yeah.
it is bilateral.
Yes, ma'am. So
Okay.
for her, it was few fingers of either hand would get involved. This is how
Yes.
she gave the history.
Yes,
Yeah.
yes. Good.
Yeah.
Yeah, I think you can go
Okay.
ahead.
Yeah, go ahead.
Okay, so summarizing my case, 43-year-old female presenting with Raynaud's phenomena with history of distal ulceration and autoimputation and skin thickening for past 6 years, sclerodactyly, GERD with dry cough for past 4 to 5 year duration, exertional breathlessness, MMRC grade 2 of 1 year duration, chronic symmetrical inflammatory arthritis of duration. Shall I go ahead, sir?
Yes,
On
yes.
history, how can you say sclerodactyly?
Sir, she had history of swelling of the entire digit and it slowly bent, sir. While she gave that history and she's not able to extend her fingers now, either actively
Okay.
or passively, sir. So this was in favor of sclerodactyly.
Okay.
Yes,
And
sir.
don't you want to say something about arthritis? Is that
Uh,
important? Or?
Arthritis is definitely important, sir. She has a chronic symmetrical inflammatory polyarthritis of around 1 year duration. So that is also important, sir.
Okay. Why is it?
Sir, if I'm thinking in
Okay,
terms of
you go ahead. We'll see in differentials.
okay, sir. Yes, sir. So, based on the history, I would like to consider my diagnosis as connective tissue disease, most likely diffuse cutaneous systemic sclerosis with Raynaud's phenomenon, ILD, uh, diffuse skin thickening, GERD, sclerodactyly, inflammatory polyarthritis with microstomia. So this will be my first differential, sir. So apart from
Okay.
that, I would also like to consider mixed connective tissue disease as my second differential and overlap connective tissue disease as my third differential.
Okay. Can you defend
Yes,
all
sir.
these things? The second and
Yes.
third one?
Yes, sir, definitely I can defend. So mixed connective tissue disease, sir, it all started with Raynaud, and he has history of synovitis. He has history of Raynaud's. He has history of uh, inflammatory polyarthritis, sir. So, like, yes, sir. It can very well be mixed connective tissue disease, sir, and that can be differentiated only based on the serological test, sir, that even and titers. So
But on
that
history, there is one point
sir, there
which is missing for
yes, sir.
mixed.
She has puffy hands, sir. She has puffy hands. She has swollen fingers. She has signs of history of synovitis. She has history of Raynaud's, sir. So all these three will go in favor of mixed and connective tissue disorder also,
Yeah,
sir.
But you mentioned
But my
that
first,
she
yeah,
had no myositis or
no myositis, sir.
muscle
I mentioned,
weakness. Yeah.
no, sir,
So
no, sir, no. She did not have, sir.
that's why I think MCTD would be lower than overlap.
Yeah. Okay, sir.
And on history,
We,
how would you differentiate between a diffuse and a limited scleroderma?
Okay, sir. Okay, ma'am. So basically, the limited cutaneous scleroderma is limited to the elbows and knees. And she had history of involvement of the both arm as well as the thigh as well. Thigh also she gave history of, ma'am. So that was going against limited cutaneous, and yeah.
Right.
So, and one more thing was there, one more point was there, ma'am. Since the Raynaud's and other systemic manifestation, they all started all together. In case of limited cutaneous, generally the Raynaud's precedes the other symptoms by almost 4 to 5 years.
Oh.
So that was also another point in favor of diffuse cutaneous systemic sclerosis, ma'am.
Right.
One more point is cough is there, which suggests
Yeah.
that there is parenchymal involvement rather
Yes,
than
sir.
isolated PAH.
Yes, sir.
What
It was
about
more of yes.
yeah, go ahead.
Yes, sir. No, you're asking something, sir.
What about this overlap? Why you say that this could be overlap?
Okay, she has symptoms of systemic sclerosis and this inflammatory polyarthritis for past 1 year duration. So that also has to be looked in, sir, and there can be very well possibility of uh, uh, overlap with rheumatoid arthritis.
Right. So what are the features of that disease? overlap? I mean,
Sir,
how the arthritis in systemic sclerosis and overlap, they're different.
okay, sir. So systemic sclerosis generally it is non-erasive, non-deforming arthritis is there, sir. Sometimes Jacquard arthropathy can also be seen if it is associated with systemic lupus erythematosus. But erosions can also be seen, sir. It is not like there are two different diseases occurring together in a single patient, sir. But it is
Yes.
more of arthralgia. It is more of arthritis that is non-erosive.
Right. And there are some
Yes.
points on investigations also. We'll see at
Yes,
that
sir.
time.
Yes, sir. Okay. Yes, sir.
I think you can go ahead.
Shall I? Okay. Yeah. Thank you, ma'am. So coming to the examination, her height was 150 centimeter, weight is around 42, BMI is around 18.6. Blood pressure was 114 by 74, right arm supine position. Pulse was 78 regular, adequate volume, normal character. There was all peripheral pulses were felt without any radial or radiofemoral delay. And the condition of vessel wall were normal. Respiratory rate around 18 per minute, thoracoabdominal in character. JVP 4 centimeter above the sternal angle. General physical examination, pyelorectus, clubbing, cyanosis, lymphadenopathy were absent. Did not give consent for a facial photographs. I have some photographs of hands only. So her hair appears to be normal. There was no signs of any patchy or diffuse alopecia. Eye appears to be normal. Face, she has a pointed nose, radial furrowing noted around the lips. There was also a thinning of lips with prominent central incisors were noted. Multiple linear to oval dilated purple to red color cutaneous vessels over the bilateral cheek and palms were also noted. That is suggestive of telangiectasias. I think few telangiectasia are visible in this hand.
Yes.
In the picture, yes. So oral cavity, she is unable to open her mouth beyond 2 fingers. The distance between the inner border of the lips is around 25 millimeter. There were no signs of active or any healed ulcers. There were no signs of any dental caries or gum atrophy. Salivary pool appears to be around the lingual frenum. This is the picture of her hand. So she has swollen fingers. The second, third, fourth, and fifth, all the fingers were swollen, and the loss of wrinkle at the PIPs and DIPs were noted at in fifth finger. Other fingers, they're there. Loss of values between the MCT, that is suggestive of the swelling. Fixed flexion deformity was also there. It was not non-reducible. Loss of pulses space was also noted, which was evident by overhanging nails. Multiple pitting scars were also noted at the multiple fingertips. Skin appears to be thickened on both forearm, arm, hand, both legs, and dorsum of the foot. This was the modified Rodman score I had calculated. The score was 18 out of 51. Shall I go ahead, sir? You're asking something?
No. You finish the examination then.
Okay, sir. Then musculoskeletal examination. PIP, DIPs, and MCPs. So entire digits were swollen, especially the second, third, fourth, and fifth fingers. Fixed flexion deformity was noted, but there was no tenderness. So I'll tell the positive finding only. So knee on inspection appears to be swollen on the left side, and on palpation, it appeared to be warm, tender. Patellar tip was also positive, suggestive of some fluid. Range of motion slightly restricted, and there were no obvious crepitus hurt or hurt. Respiratory system, upper respiratory tract appears to be normal. Lower respiratory tract chest extension was around 5 mm. On auscultation and respiratory crepitation, valvular crepitation was heard in the bilateral lower field. Lower lobe. GI system, abdomen appears to be soft, non-tender. There were no cardiovascular system, S1, S2 appears to be normal. There were no murmurs. CMS higher mental function are normal. She was well oriented to time, place, and person. Cranial mass appears to be normal. There are no signs of any sensory or motor involvement. And plantar was bilateral flexor. Yes. Shall I go ahead? Sir.
So in the general examination, you said about height and weight.
Yes, sir.
So what is the importance of weight, or is it necessary, or we can skip that in
No,
a
sir.
busy OPD? Yeah.
It is definitely necessary, sir, because the weight is also important for calculating the doses of the drugs, sir. And if there is yes, sir. And if the weight is low, sir, and since we are dealing with the connective tissue diseases, and multiple of them are associated with the chances of malignancy, sir. So because of that, also it is important. And apart from that, sir,
So if weight is very low,
yes, sir.
do you think in this particular case it is pointing towards any system, or
Yes,
we
sir.
should be very cautious?
It is pointing towards the, sir, maybe due to the involvement of the GI system, sir, because the malabsorption is a quite common thing in systemic sclerosis, sir. So that can be another possibility. Yes, sir. And since the disease is some 5 to 6 year duration, she is giving history of, sir. So I should be also thinking of associated malignancy, and I should be ruling out the possibility of any malignancy if I'm suspecting to have.
Yes, okay. One thing which we forgot to ask is, have you asked any negative history about GI system then there? What symptoms you
Sir,
expect?
yes, sir. Yes, sir. Negative history, sir. I'll go to the slides. So I had asked. So constipation, diarrhea, any black color stool or any blood in stool. So this history I had asked. This
Okay,
negative
but
history
what
I've
are
taken,
the
sir.
more common symptoms than constipation, diarrhea?
Bloating is an is
Yeah,
one
yeah.
complication. Yes, sir. Bloating is another one complication, sir. Yes, sir.
So bloating, what bloating suggests? Which
Sir, bacterial.
part of intestine is involved?
Sir, bloating can be due to the small intestine involvement, sir, and mainly due to the bacterial overgrowth, sir.
Yes, SIBO. Yeah,
yes, sir.
go ahead.
Yes, sir.
Nina, you want to ask something?
No, you can go ahead.
So based on the history of
The other thing is in the examination you said upper respiratory tract normal. So
yes, sir.
how you examined the upper respiratory tract?
So I looked for nasal mucosa, sir, if there is any ulceration or anything, sir. So that may be seen in case of any overlap with the SLE. Mucosal ulcer, nasal mucosal ulcer also can be found, sir. And apart from that, sir,
So I mean, what do you mean by upper respiratory
upper
tract normal?
respiratory tract. Okay, sir. So basically, sir, if there is any like saddle nose deformity, I was not thinking in this case, sir, but yes. So apart from nasal mucosa, use of accessory muscles can also be a feature of uh, lung involvement in such diseases, sir. So that was not there. So
I think that is better to not utter these things. Maybe
yes,
that will invite some unnecessary questions. But if you far-fetched your idea, sometimes systemic sclerosis can be associated with ANCA vasculitis. So in that way, but it is very rare, very, very rare.
it is very, very rare, sir. Yeah, very rare, sir.
So
Yes.
in that way you can defend, but maybe
Yes, sir.
it's better to avoid this.
Okay, sir.
When you're saying blood in stools, any particular condition in scleroderma you are looking for?
I'm looking for GAVE,
Right.
gastric enteral vascular ectasia.
Right.
Yes.
Go on.
So, based on the history and clinical examination, I would like to defend my diagnosis as systemic. First diagnosis as diffuse cutaneous systemic sclerosis, Raynaud's phenomenon, ILD, diffuse skin thickening, GERD, arthritis, and microstomia. However, the possibility of MCTD and overlap still there, sir. So that I have to confirm with the lab investigations.
Okay.
Okay.
Yes.
I think you can go on.
Okay, ma'am. So investigation. So her initial blood lab, uh, 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 everything appears to be normal. Rheumatoid factor CCP came negative, ruling out the possibility of rheumatoid arthritis. ESR was little high, 23. CRP was also borderline high. TSS was also normal. So her ANA that we did ANA by immunofluorescence, it came 3+ core speckle positive. ANA blot showed SCL70 strong positivity with borderline positivity for WHO and TCNA. We also did NFC for her. So she had few capillaries and some capillary dropouts, some adplications, suggestive of active disease in this case. HRCT had shown some ground glassing opacities in basically in the basal area. However, the subpleural sparing was not noted. I have just tagged this. This is the real images only, sir. So she had minimal, some cystic changes were also there, looked like honeycombing with some subpleural ground glassing opacities were there. And in this particular CT, I have also noticed generally the esophagus is not visible in such situation, but here I think it is generally collapsed in the CT. So that was also going in favor of scleroderma related esophageal pathology. 2D echo, apart from grade 1 diastolic dysfunction, everything appears to be normal. This was the investigation we did.
Which antibodies you expect other than SCL70 to be present in diffuse scleroderma?
So another is RNA polymerase 3, ma'am, is another antibody that is present.
Right. And this RNA polymerase 3, what other things can be there in it?
Ma'am, it can be associated with three things. One is the scleroderma renal crisis, tendon friction rub, and also it is associated with malignancy. Chances of malignancy are also higher with this antibody.
And even GAVE chances are also higher.
Yes, GAVE chances also higher with RNA polymerase 3. Yes, sir.
What are the predisposing factors for patients to develop renal crisis?
One is the antibody positivity, RNA polymerase 3 antibody positivity, and the history of high steroid intake. Yes, ma'am.
Above
so
how
that
much?
Is another.
Above how much mg is considered to be a risk?
More than 10.
Yeah, so more than 15 generally is considered to be a risk. And one more thing, more important, is when there's rapid skin involvement.
Yes, rapid skin involvement. Yes, and tendon friction rub is also associated with chances of developing SRC.
Right.
Yes.
So some basic questions. In how many percentage of systemic sclerosis patients you have ANA positivity?
In systemic sclerosis,
yeah.
Sir, around 90%. I'm not very sure, sir. I think around 90%.
Yeah, different books say different number,
yes,
but maybe 90 to 95%.
Yes, sir.
So in a patients who have Raynauds and they don't have any positivity, you think of other diseases, and how many percentage of MCTD patients you have ANA positivity?
So, sir, to have MCTD, sir, the entry criteria itself is like we have the 4 criteria, sir. We have one SHARP criteria, we have Larkin Segovia criteria and Kahn criteria and also Kasukawa criteria. So all the criteria, the NA positivity is a entry criteria, sir.
Right.
To
So
say
100%.
NC3,
The answer
given
is
NP
100%.
titers. Yes, sir, 100%. Yes, sir.
Yeah. And is it possible that in diffuse systemic sclerosis you get anti-centromere antibodies?
In diffuse, sir, I'm not very sure, sir. I think we can have. The patient
So
can.
some 5% patients
Yes.
will have. And
Okay, sir.
how many percentage of patients of diffuse systemic sclerosis have SCL70 positivity?
75 to 80%, sir. 75.
No, maybe 40%. So is it necessary that to call a diagnosis as diffuse, you should have SCL70 positivity?
No, sir, it is not necessary, sir.
So
Skin thickening alone, sir, if it is extending proximal to the MCP, sir, that itself we get a score of 9, sir, and the 9 is the required score to define case of systemic sclerosis, diffuse cutaneous. I mean, systemic sclerosis. Yes.
but that is what? That is classification criteria.
Yeah, classification criteria. Yes.
That is not diagnostic criteria.
Yes.
Yeah, and you described about some esophageal symptoms also. So do you want
Yes.
to do any other investigation in this patient?
Yes, sir. So she's having symptoms of GERD, sir. I would like to go for 24-hour pH monitoring, sir, to establish the diagnosis. And also we can go for manometry, sir, for the esophageal mortality to document that. And apart from that, sir, upper GI endoscopy is also a required investigative tool, sir, that will tell us about the emitter of the esophagus. So one thing, and another thing, sir, it can also tell us about the pathologies that is lying in the stomach, such as watermelon stomach or.
Yeah.
Yes, sir.
So do you want to do endoscopy in all patients of diffuse systemic sclerosis? Or are there any particular indications?
Sir, if the patient is losing weight, sir, or if the patient is having recurrent iron deficiency anemia, sir, so that is a indication for upper GI endoscopy. Because sometimes the patient may not have symptoms of melena, but the patient still have iron deficiency anemia, and they may be losing some blood into in the stools. So that is also an indication for upper GI endoscopy.
There are other conditions also.
And
if patients have, yeah, go ahead.
Yes, sir. Yes, sir. If the patient has weight loss or significant weight loss, so to document the possibility of any adenocarcinoma, sir, that is also a possibility. That is also indication for upper GI endoscopy, sir, and to take the biopsy from the affected area.
Yeah.
Yes,
Other things are if patients have odynophagia, sometimes these patients have esophageal candidiasis, and
yes,
if there are disappearance of GERD symptoms, it can be because of lower end of strictures. So to document that, and if you find strictures for dilatation also, you need repeated
yes, sir.
endoscopies.
Yes, sir.
Okay, go ahead. Yeah.
So that will be all, sir. So,
So how would you go ahead with treating this patient?
So, ma'am, since the patient has, the approach for treatment in scleroderma is basically, ma'am, it is quite variable. It depends on the symptoms and the manifestations. So the patient is having Raynauds. So for Raynauds, we have multiple options. Still, the calcium channel blockers are the preferred one. And we also have the endothelin antagonist like bosentan. And we have the phosphodiesterase 5 inhibitors such as sildenafil or tadalafil. But out of these three, the calcium channel blockers are the preferred one according to the recent guidelines, as it prevents the further distal ulcers
Which one would you
from a
prefer?
calcium channel blockers, ma'am.
No, in calcium channel blockers also
Nifed,
short. Okay.
yeah, ma'am. Nifedipine, ma'am.
Long acting calcium channel blockers. Yes. Okay.
Yes, ma'am. So that is there, sir, ma'am. So if the patient, since the patient is also having features of ILD, so we have to do PFT. PFT. Uh, we'll also go for PFT to document the various like to document the restrictive lung disease. So and also to do DLCO to document the possibility of PAH. But since this patient, the 2T was normal, it appears to be so there are further guidelines are there. So we have if the patient has lung fibrosis more than 20%, and the patient is also having PFT changes, so we should be monitoring it quite frequently. And if suppose there is worsening of the symptoms, we should be repeating the HRCT to look for the progression. That progression is defined by and also the PFT. The progression is defined by the fall in FVC by more than 10% over a year, or maybe if or FVC, the fall in FVC between 5 to 10%, with fall in DLCO by more than 15%. So that is an indication for to go for the immunosuppressive therapy. So other for the ILDs, the preferred one is MMF in the such scenario because of the better tolerability. Other options are also there, cyclophosphamide. So according to the studies, that SLS2 study, the mycophenolate is a well tolerated and has the similar efficacy as the cyclophosphamide and has the lesser side effect profile. So
So in your
that is
exam, don't say MMF anytime. Say mycophenolate most of the
mycophenolate.
year.
Yes, ma'am. Mycophenolate.
How frequently will you repeat the PFTs and HRCT?
Okay, sir. So if the patient has evidence of ILD and the extent of fibrosis is less than 20%, so the PFT are required to be repeated every 4 to 6 months, and HRCT uh, uh, based on the symptoms. If the worsening of the symptoms are there, then only HRCT. And if the extent of fibrosis is more than of 20%, then PFT may be will require to repeat in 4 to 6 months, and HRCT in 1 year.
Okay, so what could be the possible causes of worsening of respiratory symptoms in this patient?
One is to sir progression of ILD only,
Yes.
and other can be sir infections.
Yes.
Yes, sir. And the very less likely, sir, very less probability of, but still there the chances of malignancies are also there in the if the patient has ILD, the patient are more prone to have lung carcinoma, sir. Mostly squamous cell
Yeah.
carcinoma. So yes, sir.
pH also, worsening of pH.
Yes, sir. Worsening of pH is also yes, sir.
Yeah.
So the patient
And
has more of
sometimes very simple thing, anemias
yes, sir.
because of blood loss and
Because of the blood loss. Yes, sir.
malabsorption, vitamin B12
Malabsorption.
deficiency.
Yes, sir.
Yeah. So any other clinical test which you would like to do in your clinic when the patient is there?
Yes, sir. We would like to do a 6-minute walk test for these patients, sir. But since the patient, our patient had pain in the left knee, sir, so we couldn't do because we'll falsely get the values. So 6-minute walk test is also a requirement, sir, to establish. Yes, sir. That is also we can do in the clinics.
Okay.
Yes.
Can you tell us about the role of antifibrotic in these patients, other than your immunosuppression?
So, antifibrotic, we have two antifibrotics, pirfenidone is approved by FDA only for IPF. but nintedanib is approved in 2019 by FDA for to use in cystic sclerosis, and it is to be used advancing. So that can be add on. There is one some SLS3 trial is also was going on. The paper is not yet published, ma'am. So
Okay.
that there they had compare. The aim of the study was to MMF with pirfenidone, but the results are not yet out. So pirfenidone definitely, nintedanib definitely we can use, but only in the case of progressive disease, ma'am. And it also has the GI side effects. So
Right. Right.
yes,
Right. So we
yes,
don't
ma'am.
use it in all our patients, at least at
No,
present, only
no.
selected patients.
Yes,
Right.
yes, ma'am. Selected patients only. But again, the same definition, ma'am. The fall in FVC by 10% over a year, or fall in FVC between 5 to 10% with fall in DLCO by 15%. That is the indication for to use antifibrotics, ma'am.
Okay.
Yes, ma'am.
Any role of tadalafil in this patient? You mentioned it that you would prefer calcium channel
Yes,
blockers,
sir.
but
Yes, sir. Raynauds. Yes, sir. In view of Raynauds, we can start. Uh, it has roles, and apart from that, since the pulmonary arterial hypertension is not documented in this patient, so the only indication is the uh, uh, Raynaud's phenomenon, sir, in this patient.
tadalafil is known to prevent digital ulcers also. So, or
Yes, sir.
bosentan.
Yes, sir. Yes, sir. Both tadalafil, yes, sir. Phosphodiesterase 5 inhibitors are known to prevent distal ulcers, sir. And calcium channel blockers, they are used for to treat the distal ulcer, as well as they have the potential to prevent the further distal ulcer as well, sir. So that is why it is the preferred one.
Okay, so in this patient, what would you prefer, mycophenolate or cyclophosphamide or any other drug? What you want to give?
Sir, in this patient, she was already, sir, as I gave the told the history, sir, she was started on some tablet that initially was given as one tablet BD, then later on it was made to two tablet BD. That was most likely mycophenolate only, but she had some GI upset with that medication. That we can change the salt, sir, and yes, so we can change the salt and we can see if she is tolerating it well, then we can go ahead with the MMF. But sorry, mycophenolate, but it won't take care of the joint symptoms.
Right.
So yes, so because of the joint symptoms, we have started her on rituximab. We have an ILD, like both. It will cover both the parts. Yes. Yes.
Okay.
Yes.
So any role of new molecule which is always prescribed nowadays? Tofacitinib.
Tofacitinib, sir, off label, we can use it for the inflammatory polyarthritis, sir, in this patient.
How do you
Okay.
treat an episode of very severe digital gangrene? Means
Okay,
ischemia leading to
okay.
gangrene?
So critical ischemia, ma'am.
Yes.
So the preferred one is the prostaglandins, ma'am. Maybe IV iloprost infusions are preferred one in those situations. Um, yes,
Right.
ma'am.
And if you don't have, yeah. So many times
Yes.
we might not have the settings to give IV prostacyclin. So what any other things would you do?
So
Is there any role of heparin or anticoagulation in?
it has a role, ma'am. It has a role
In
in
critical ischemia,
treating
it
this.
has a role. So you can use
Critical.
heparin in critical ischemia.
Yes, ma'am.
Right.
Yes, ma'am.
And then finally, even low sympathectomies also can be
Yeah.
done if you don't
Yeah,
have
ma'am. Surgery.
prostacyclin.
Yes. Yes.
Right.
Digital sympathectomy we can go ahead with.
Yes.
Yes.
Avinash, anything else you want to ask?
No. That is all. I think you have done a good job.
Yes, yes. Good
Kavita madam
presentation.
told to keep some few minutes for
Feedback, yeah.
feedback.
Yes. Thank you, sir.
So you can just probably just tell him where he can improve, or that way. Both of you, okay, just give a short feedback. Yeah.
He's presented it quite well. So covered the history and examination part and even the theoretical part very well. So it's a really good presentation.
Yeah. Okay. Anything else,
Thank
Dr.
you, ma'am.
Yeah, he presented well. The symptomatology he presented well. Few investigations he missed. I think he missed PFT, so he has to include that. And the order of differentials, maybe overlap would be more than MCTD. But
Okay.
all in all, I will give him 7.5 out of 10, maybe.
Thank
Okay.
you, sir.
So I think that was there was one question in the chat box. Maybe one of you can take it. In case of established, this is okay. I think you've already answered. In case of established digital gangrene in Raynauds, what can be done if they develop despite CCBs and tadalafil? I think critical ischemia have answered, but in
Yes.
OPD patients, what would you like to add? That is one question.
In
Do you
addition,
answer that?
so in addition to what? Calcium channel blockers and
And
tadalafil.
tadalafil, yeah. So you talked about critical ischemia, you know.
Yes,
But
yes.
outpatient, would you like to add anything?
Like addition of again ecosprin also in our outpatient patients, local nitroglycerin patches,
Yeah,
which some that also help. Sometimes they're not very much available, but they help in local ischemia when the patient is not admitted.
right.
The other thing is pain can be because of infections also. Most of the times we see infections, so appropriate culture and antibiotics, mostly gram positive cover, will help in that also.
Yeah, and there was one comment, alprostadil. Iloprost is not available. So what we use is alprostadil. Yeah, and some of the attendees have answered some of the questions well in the chat box. They kept answering. Yeah, all of them are correct. Yeah, Dr. Sasikala. Yeah, thank you. So thank you, Dr. Avinash and Dr. Neena. It was a very smooth and well conducted case presentation. Thank you for sparing your time today.
Thank you, ma'am.
Yeah,
Thank you, ma'am. Yeah, thanks.
hope to see you soon again.
Thank you, ma'am.
Yes, yes, yes. Thank you.
Shyam, you can stop sharing your
Thank
screen.
you. Yes, ma'am.
So now we have a very interesting lecture. Yeah, Dr. Rajeshwari ma'am, you can start sharing your screen. Prasad, please help ma'am if there's any technical.
Yes, ma'am. Sure.
Yeah. So today we have a very reputed rheumatologist from Chennai, Dr. Rajeshwari ma'am. She is well known to all of you, but still I'll just introduce her. Presently, she is the professor and head at Srihar Medical College, Chennai. She started the first department of rheumatology at Government Kilpauk Medical College in 2012 and received the Independence Day Award for Meritorious Service in 2013 at Kilpauk Medical College. She's a graduate of Madras Medical College, DM from there, and she upgraded the Department of Rheumatology, the first institute in India exclusively for rheumatology, as Institute of Rheumatology at Madras Medical College, Chennai, on July 8, 2015. She was the first director at MMC on Medical on September 16, 2015. She received prestigious IRA Oration at IRACON 2018 at Guwahati, Assam on December 7. She's won 4 times the Best Poster Award at IRACON 4 times. She has got multiple publications to her credit. I welcome you, ma'am, for our Maharashtra Rheumatology Association program. Today, ma'am will be talking about large vessel vasculitis and the differences and the mimics. So, ma'am, over to you. I welcome you to the session today.
Thank you so much, Dr. Kavita. Am I audible?
Yes, ma'am. Yes, yes.
Yeah. And thank you, Maharashtra Rheumatology Association, and thank you all members of the audience. Vasculitis is the topic today is large vessel vasculitis, differences between the two major large vessel vasculitis and the mimics. Very often we miss out the mimics. We limit ourselves to only few mimics because our knowledge is very scanty. And this speech is only to enlighten us about what are the other conditions we should think about when we approach a case of large vessel vasculitis. The first few slides will be general slides on description of vasculitis. They are a heterogeneous group of disorders producing inflammation, as all we know, as all of us know, within the blood vessels. The end results are necrosis, aneurysmal dilatation, stenosis, occlusion of lumen due to the inflammation, and finally thrombus formation. And in case there are no collaterals, it will result in aneurysm, narrowing or occlusion of the arteries, concerned arteries. Plural term is vasculitis, and vasculopathies are non-inflammatory occlusive conditions. Now, what could be the clinic? This is the biggest dilemma we face in clinical practice. So there are myriad manifestations of any vasculitis for that matter. And among these, for the large vessel vasculitis, what would fit in here will be weight loss, arthralgia, arthritis, hypertension, renal failure, seizures, and rarely myocardial infarction if the coronary arteries are also affected. Now, we should know there's a considerable overlap between all the types of vasculitis. The green one is a large vessel, the blue is a medium vessel, and the brown is a small vessel vasculitis. So there will be an overlap between all of these. The large vessels affecting mainly the large vessels, and then a mild overlap between the large and medium and small. So we are concerned today mainly with the large vessel vasculitis, and the major two conditions are Takayasu and giant cell arteritis. This is a beautiful slide just to show the pathology of the different types of vasculitis, the large, medium, and small. And most of the two major large vessel vasculitis are giant cell and Takayasu, as I already told you. The age group is very important because in GCA is greater than 50, and usually in Takayasu, more of females, less than 50 years, and both of them are granulomatous arthritis. Now, we'll just speed ahead with the various classes because many students are here. There are various classifications for Takayasu and giant cell arteritis. It all started with the GCA 1990 ACR, and here we have five criteria, out of which it should satisfy greater than 3 with new onset headache, age, of course, temporal artery abnormality, elevated ESR greater than 50, and an abnormal temporal artery biopsy. Mark this temporal artery biopsy because in the latest classification, it may not be really mandatory to have a temporal artery biopsy. And almost always GCA or temporal arteritis is accompanied by polymyalgia rheumatica, which is often missed. Any female or male for that matter, aged greater than 50 years, if they come with incapacitating stiffness of the neck, shoulders, shoulder girdles, and hip girdle muscles, the possibility of polymyalgia rheumatica should be entertained. So initially, Das Gupta and colleagues, they framed a criteria with ultrasound and without ultrasound because shoulder girdle and hip girdle muscles are affected. And the early morning stiffness is greater than 45 minutes. They gave weightage for this criteria for those with ultrasound and without ultrasound. Without ultrasound, it should be greater than 4, and with ultrasound, it should be greater than 5. However, all these criteria have been modified later. And for Takayasu, again, the ACR 1990, we have 6 criteria here, and any 3 of the above should be positive for us to call it as Takayasu. Again, here it's age less than 40 years. Remember, the new DCVAS classification gives a very controversial figure of between 50 and 60, which I think cannot be acceptable at all, because as what I'll be talking later, the differences between Takayasu and GCA are very clear. Though people are telling there's a lot of overlap between both, we have to distinguish between both these. And the next point, which has been modified in the latest criteria, is the difference of systolic BP greater than 10. They've increased it to 20. And they've given weightage. Chapel Hill 2012, again, a very simple classification. It's based on the original Chapel Hill, large vessel being Takayasu and giant cell. And again, they have included the isolated aortitis and single organ vasculitis. So, and then the other vasculitis belonging to the systemic connective tissue, all these also can produce large vessel involvement, including Bechet. Now, this is the latest criteria, the ACR criteria 2022 for GCA. Here they've given what consideration should be taken before applying these criteria, and how we have to rule out mimics, and the age, the absolute criteria requirements are greater than 50 years. Then we have the additional clinical and laboratory criteria, and they have given great weightage to the sudden visual loss here in the GCA. And in the great weightage of a higher weightage of plus 5 points have been given to either a positive temporal artery biopsy, or we have to demonstrate a halo sign on temporal artery ultrasound. So that's good enough now. That's very good news for us. And coming to the 2022 for PMR, they have clubbed both with ultrasound and without ultrasound together here. And they have given the age greater than 50, bilateral shoulder pain, and an abnormal ESR or CRP, that they should be the essential ones, required criteria, and more weightage for the morning stiffness and negative RFN anti-CCP antibodies. And of course, the ultrasound findings. And again, this should be greater than 5. Now, coming to the other criteria for Takayasu, now this is the ACR 2022. Again, see here they have given age less than 60 years. It need not be less than, because you're going to have an ambiguity between 50 and 60. So going with Takayasu or GCA. So for many of the diseases, more than 75% of the Takayasu, we see only below 50. So that has to be kept in mind before we jump into this criteria. They have included a lot of other clinical points here, and they have given less weightage for the female sex, and for systolic blood pressure, they've included greater than 20 millimeters of mercury. And in the imaging criteria, this is a good one. They've given a lot of weightage for 3 or more arterial territories, which will be plus 3 points. Again, you sum up these items, and over a score of 10, you have to have greater than 5 to call it TAC. Now, coming to some differences between TAC and GCA. First, we'll discuss about the similarities. Both have female predominance. Both have an etiological agent like an infection. Both have genetic involvement like IL-12B SNP polymorphism in this huge numbered gene. And both are granulomatous and produce granulomatous inflammation. Both have cell-mediated immunity. Both have Th1 and Th17 and high IL-6 and IL-17 levels. And both are favorable to show a favorable response to steroids and IL-6 treatments. Now, certain other differences now. We'll come to this. The names, Takayasu, all of us know it's called by various other names like Pulsar's disease, occlusive thrombocytopathy, non-specific iotitis, Arch syndrome, middle aortic syndrome, Marshall's disease, and granulomatous again, temporal arteritis or GCA. And the age, again, see, this we've taken from the statistics and what we've been seeing over years. So it's less than 40 years for TAC and greater than 50 years for GCA. And the mean age is 25 for TAC and 72 for GCA. Gender, again, female to male is greater in both. And of course, you have the geographical variation. Genetics, it's very distinct. Genetically, they differ from each other. TAC is due to HLA-BW52, with other genes like DW12, 2, and DQ1, W1, and of course, all of us know age-old TNF alpha 308AG polymorphism. And for GCA, we have the HLA-DRB1 0401 and 0101. However, the B52 allele, MLX gene, and the SNP polymorphism in the IL-12B region have been correlated with the severity and aortic regurgitation in Takayasu. Now, what are the vessels that are involved in Takayasu versus GCA? This again is quite easy to distinguish, but clinically, when you see an overlap between the vessel involvement in both, it may be difficult. The left subclavian, of course, is more common in Takayasu, followed by the aorta, followed by the common carotids. Whereas in GCA, you have the extracranial branches of the carotid artery, and of course, the superficial temporal artery, the vertebral artery, and the ophthalmic artery. Infections, TB, of course, for TAC, and for GCA, you have varying infections like varicella, mycoplasma pneumoniae, parvovirus, and a parainfluenza. Pathology, remember, when you see in the early stage, it's very easy to differentiate because Takayasu always starts from the adventitia, goes to the media, and then goes to the intima. And here, there's a lot of fibrosis. Adventitial fibrosis and scarring is very gross in Takayasu. Whereas in GCA, it starts from the intima and proceeds to the adventitia. So the inner media inflammation and then later on to the adventitia. Both of them have granulomas. And here, both can produce a man arthritis also. And already we've spoken about the MHC, the class 1 and class 2 in TAC and GCA respectively. Now coming to the T cell mediated cytokines, Th1 and Th17 play a role in both. However, what is the importance of these two? When they are Th1 interferon gamma positive, they are steroid sensitive in TAC. Whereas in GCA, it is a Th17 or IL-17 production who respond to steroids very well. Pathology here, micropathology aneurysms are actually more in GCA rather than Takayasu. In both aneurysms can occur. The stenosis is more along with aneurysms in Takayasu. And here you see a beautiful diagram. This shows the carotids and the temporal arteries. And this is the GCA pathology starting from the intima, going right through the media to the adventitia. And this is Takayasu starting from the adventitia and coming to the media. And of course, all the T cell mediated ones and giant cell, CD4, monocytes, macrophages, endothelium, endothelial cells, the gamma delta cells, and CD8 and B cells also do play a role, because this is important when we come to the therapy. Pattern is here in Takayasu, it's continuous or it may be segmental, but in GCA, it's almost always segmental or skip lesions. Claudication, bruit, absent pulses, BP discrepancies are all very common in TAC, whereas headache, jaw claudication, anterior ischemic optic neuropathy, AAON, PMR are all very common in GCA. Renal hypertension, as all of us know, very common in Takayasu because mainly of the stenotic lesions. Pulmonary artery also is commoner compared to GCA. Aortic involvement, here you have stenotic lesions, whereas here you have thoracic aneurysmal dilatation in GCA. And of course, as far as the carotids are concerned, ICA is more common in TAC, whereas branches of ECA is more common in GCA. And of course, left subclavian, according to the latest cluster classification framed by Ruchika and co, Ruchika et al., we have the left subclavian, bilateral carotids, and mesenteric artery all favoring TAC, with the symmetrical subclavian and axillary arteries are almost always never involved in Takayasu. So these are all very important distinguishing features between both. And then you see this slide I've just put just to show the constitutional features which can occur as vasculitis, which we should not miss in this age group, like in chronological order: headache, weight loss, fever, fatigue, any visual symptom, anorexia, jaw claudication, especially for GCA. It may not occur in Takayasu at all. And the PMR with GCA, arthralgia, visual loss, again, unilateral and bilateral for GCA, which is very late in Takayasu, though it may occur. Vertigo and diplopia, all very common for GCA. And this diagram, this picture shows one of our patients who had the papilledema, and you can see the dilated tortuous temporal arteries, very tender, explicitly tender. Sometimes the temporal artery may not pick up the halo sign, or the biopsy may be negative in the major artery. You have to go to the supraorbital branch or one of the branches, the end artery sort of arteries from the temporal artery, to pick up the resistance to the blood flow and to seek a halo sign. But we cannot biopsy these areas. The temporal artery is, of course, the best one. And this shows the grossly thickened intima, the media, the adventitia of thing. And you can see multiple giant cells over here. And early enough, it will cause splitting of the internal elastic lamina here and proceed to the media and then to the adventitia, which is a late occurrence in Takayasu because it starts from adventitia and goes inside. In the late stages, it may be difficult to distinguish between both. Now, how are you going to distinguish between these two? As far as imaging is concerned, both have an increased intima media thickness. You see these two arrows, this is intima media thickness, which is increased. Normal is 0.6 to 0.7 millimeters, whereas here it may be anything greater than that. We have a set protocol for Indians. We have a cutoff value. So depending on the age, it will increase by 0.1 every year. So this is a thickened intima. This is called a macaroni sign in Takayasu. It's very uniformly thickened. This is the intima media, that junction. This is the macaroni sign. And the same thing occurs in the temporal artery, which is called as a halo sign. And this is a normal triple flow in the Doppler. It has to be a triphasic flow. When it becomes a diphasic or a monophasic, showing only one of the phases, you know there is resistance to the blood flow. What are the methods of other methods of imaging we use? Conventional angiography, we know it's no longer done except per operative. CTA is a very good technique except for the irradiation, but it may not pick up the edema of the vessel wall as well as in MR angio. Hence, MR angio is preferred for Takayasu and for GCA next to the ultrasound. In Takayasu, MRA is the preferred technique, but CT also is good enough. So ULAB guidelines tell these, the color Doppler or contrast in ultrasound for GCA and for follow-up. That's the best one. And MRA alternative to color Doppler for GCA. For TAC, it's only MRI. All of you know about this Takayasu presentation. This is a pneumono scoring, angiographic, arch vessels, one, arch as arch of aorta, ascending aorta, arch of aorta, vessels 2A, and then the 2A plus descending aorta is 2B, and then descending thoracic, abdominal plus or minus renals is 3, only abdominal is 4 without renals, and all put together is 5, and that can include coronary or pulmonary artery, yes or minus. And this is the cluster classification I told you. The first 3 clusters are in favor of Takayasu. The next 3 clusters are in favor of GCA. So what is the first cluster? This is the abdominal with the darker shades point to the severity. So abdominal aorta, renals, and then you have the left subclavian and the carotid. And when you have only the upper limb arteries, it's cluster 2. And only when you have only the left subclavian, it's cluster 3. Whereas for GCA, here you can see the bilateral involvement and the whole, almost the whole of the aorta here. And iliac is not at all common in Takayasu, but that has been found to be involved in GCA. Cluster 6 shows only the bilateral axillary arteries. Coming to treatment, of course, we know glucocorticoids are the drugs which we start with, both for Takayasu and in GCA. And but for GCA, they are very sensitive to steroids. Of course, next first-line drug will be methotrexate or conventional DMARD, again more effective in GCA. Not that it doesn't work in Takayasu. Azathioprine, yes, all these can be tried. Of course, we have found very good results with MMF for Takayasu compared to GCA. Cyclophosphamide, I don't know whether we really give except for very severe cases. TNF inhibitors have been found to be very good for Takayasu, but not for GCA, as good as tocilizumab. Abatacept has been found to be good for Takayasu. IL-6 receptor tocilizumab has been found to be good for both, but again, very good for relapses of GCA. Rituximab has been tried in both, but there are only case reports. Secukinumab is an ongoing trial, a very good trial for GCA because of the TH17. And JAK inhibitors, there are only case reports. Of course, trials are going on. And of course, with both upadacitinib and tocilizumab, tofacitinib, sorry. Now, how to approach large vessel vasculitis and its mimics? We always start as we do in general medicine, internal medicine. How do you approach a case, history taking in a case? Whether it's congenital or acquired, infective versus non-infective, inflammatory versus non-inflammatory. And then coming to all the mimics, it's so easy to identify because very often we miss out the congenital causes and other non-infective causes and also the infective causes. So let's proceed. Coming to the congenital one, we have these rare diseases like Erding-Chester's. They presented it at Iracon as a CPC. Common infections like tuberculosis, syphilis, retrovirus, and then you have the systemic connective tissue disorder associated large vessel vasculitis, and the disorders which come in the Chapel Hill classification under variable vessel. Actually, Cogan, which was previously clubbed, Cogan and Bechet were clubbed under large vessel, but now they've been removed to this variable vessel. And next will come the IgG4. And you have the other one, other mimics like fibromuscular dysplasia and the segmented artery medullolysis, which I discovered only for the first time when I was looking up the mimics. And of course, atherosclerosis. In the first criteria, 1990 ASIA criteria, they were given, you have to rule out angiographic confirmation after ruling out FMD and atherosclerosis. That is all. They would not have given anything else. Now we learn about all these others. I'll just take you through a short bird's eye view about these. And this is Erding-Chester. This is a congenital problem. It's a non-Langerhans histiocytosis. So that means histiocytes get deposited and produce inflammation in various organs. So it's a multi-organ disease. It can be found in the optic tract, in the pituitary. It can be found in the long bones of the legs, and it can affect the large vessels as well. Are you able to see the picture clearly?
Yes, ma'am. You can
The
see.
fourth one, D. D is visible?
The D one, yeah, maybe the arrow is pointing out to something. No? Yeah.
Okay.
It's seen here. You can just
So
maybe
here you
describe.
have the periarterial thickening of the whole aorta and its main branches. It can also result in ectasia. What do you mean by ectasia? Any enlargement or diameter less than 5 centimeter is ectasia. Anything more than that will be an aneurysm. So it can produce stenosis as well. This is due to BRAF V600 gene mutation along with MAP kinase also. And you have histiocytes laden with xanthomatous material. Of course, these are the drugs that are given. We have to know how to identify because it affects the aorta. Then the other normal one, we know that aortic coarctation, the commonest manifestation is post subclavian, left subclavian coarctation. Coming to MAFON, all of us are aware of this, and MAFON, it's an autosomal dominant, and it's due to the mutation of fibrillin-1 gene. All of us know that. The common areas affected are aortic root and dilatation and dissection. With this picture shows you the aneurysmal dilatation of the aortic annulus and the ascending aorta. Next is the Ehlers-Danlos. Again, it's an autosomal dominant with the mutation of COL1, COL-A1 and 1A1 and COL3A1 mutations. And the type 4 is the one that affects the vessels, and it can produce dissection and spontaneous aortic rupture. This is a dissection. You can see beautifully over here. Then you have the Loeys-Dietz syndrome. Again, this is an autosomal dominant. It's a TGF beta receptor 1 and 2 gene mutation. It can produce arterial tortuosity. What you see here is the aneurysm of the aorta, the dilated aortic root and the tortuous carotid arteries here. Then you have the neurofibromatosis type 1. Again, this is due to a neuro NF1 gene mutation and tumor suppression gene mutation. This can produce aneurysms. It can produce stenosis, and it can produce a coarctation-like picture. These are the aneurysmal sacs, and this is the stenosis here. And AV malformations as well. This is a commonest disease. We should never forget because in the history of Takayasu and during its growing up and having reached a stage, tuberculosis still maintains its hold as one of the etiological factors for Takayasu. So we should never forget about it. So how does this infection spread? It may be the patient may be having an active infection, or it may be due to hematogenous spread, or it may be a vessel wall erosion by contiguous adenitis, and or pseudoaneurysms also may be common. True aneurysms with aortic narrowing also can occur here. You can see the dilatation here. You can see the narrowing here. And in the C picture, you can see the pseudoaneurysm of the subclavian artery. And this is one of our own patients way down in 2007. You just see the blood flow here, and this is a huge saccular aneurysm. Saccular aneurysms are very common in infections and Behçet. So you see the blood flow, and the rest of the place is occupied by the thrombus due to the tuberculosis infection. And this is after treatment. You can see this is before treatment, and the next one is the after treatment. Next is syphilis. I don't know how many of us would have been, we've seen during our student days, but this newer generation may not have seen syphilis at all. But as all of us know, it's notorious for affecting the ascending aorta, producing an AR over there. It can also affect the coronary ostia, producing the narrowing over there. The pathology is mainly in the vasovasorum, which is due to an obliterated endarteritis. The immunity is a cell-mediated immunity here. Next is the retrovirus. Here you can have multiple aneurysms and occlusions as well. So this virus produces inflammatory mediators and then resulting in an endothelial dysfunction with smooth muscle proliferation. Adhesion molecules and cytokines and chemokines also play a role. Systemic connective tissue disorders, most of them produce a panarteritis, and especially rheumatoid can produce a granulomatous arthritis. And all of us know in late rheumatoid, we can get an aortic regurgitation. This shows the thickening, the vasculitis, the inflammation around the major vessels, and this is around the aorta. It can mimic Takayasu. The vasculitis of RA can produce like a picture like secondary Takayasu. Of course, Sjogren, SLE, and sarcoid, they all produce and iotitis and obliterative endarteritis. With granuloma, the sarcoid can also produce a granuloma. Now, coming to relapsing polychondritis, all of us know that it can affect the blood vessels. You can see the aneurysmal dilatation here, and then see this is the vessel wall thickening, which you can see over here. And this is due to an immune reaction occurring against unidentified cartilage antigens. It may be due to type 2 collagen or matulin 1. The problem is a panarteritis here, panarteritis with the loss of the elastic tissue resulting in fibrosis and hyalinization. So AR, aneurysms can occur. Coming to spondyloarthropathy, again here the aortic involvement is very, very common over here, ascending aorta and root and the annulus dilatation also. Here what happens is there is cellular inflammation and a proliferative endarteritis. You may ask why should they be in a spondyloarthropathy, a synovial joint involvement structure producing sacroiliitis? Why should it produce iotitis? Because they have very common type of collagen both in the aorta and in the sacroiliac joints, that is type 1. Behçet, the variable vessel, we know it can produce arterial and venous involvement, it can produce aneurysms, it can produce thrombosis, and the danger areas are the pulmonary arteries. You can see the aneurysms here, and then the renal artery also, and the aorta and its branches. This is a PET scan showing the uptake here. And as I said, sacral aneurysms also are common. The last picture showing the sacral aneurysms in Behçet. Then we have the IgG4 disease. Previously, we knew that we used to call it only as retroperitoneal fibrosis, as seen in the last picture down over there. When it is an isolated abdominal involvement, like retroperitoneal fibrosis surrounding the aorta, it was called as Osman's disease previously. Now we know that it's due to IgG4 plasma cell infiltration in all areas. Like this also picks up areas like the other one which I told you, which was that Erding Chester. Yeah, and the Rosé-Dorfman. They're all differential diagnosis of this. But what we are interested in this present presentation is the aortic involvement here. You can see the thickening over there. And then there may be some lymph nodes over there showing the IgG4 also. And it can produce aortitis also. Now, this is a very interesting condition and a confusing condition, the isolated aortitis versus GCA. Here, comes under the category of single organ vasculitis, which can produce inflammation of the aorta. There are no signs of systemic vasculitis or infection here. And the pathology is giant cells and lymphoplasmacytic cells. But it involves only the aorta, usually the abdominal aorta, the arch. The branches of the aorta are spare. You can see the thickening over here. And it usually occurs in a lesser age group, younger age group as opposed to GCA. And you can see the thickening here. You can see the diffuse fat stranding here. So how do we go about this? Like steroids, immunosuppressives, yes, they may be the choice. This is APLA. All of us know about the antiphospholipid antibody syndrome. What happens here is this is beautiful. This is a multi-slice CT scan showing all the vessels. You can see the iliac cutoff here. Okay. And then you can see the popliteal, the femoral, distal femoral cutoff here. And the aorta also, this iliac has been abruptly cut off, distal to the branches. So this abrupt cutoff is very, very classical of APLA. And again, you see an aneurysm here. This is the thrombotic area. This is the area with the blood flow. This is again due to antiphospholipid antibodies. It's a mimic. Now coming to another interesting condition, which I told you, which I also was not aware of, because strictly speaking, if somebody comes with an angio picture like this, and we look at it, we would have the first diagnosis would have been fibromuscular dysplasia because of the string of beads appearance here. But then let's go about this interesting condition. This is called as segmental arterial medullolysis. Male, female, equally involved 40 to 50 years. Here, the renal arteries and the visceral arteries, especially the mesenteric arteries, are very commonly involved. Classical appearance is a string of bead appearance. Dissections can occur, stenosis, alternating stenosis, and this is stenosis here. alternating stenosis and aneurysms can occur. It can also produce thrombosis. But what is it? It is due to a non-arteriosclerotic, non-inflammatory condition affecting the blood vessel wall. What happens here? The tunica media undergoes lysis, it undergoes vacuolization, and it can produce what is called as a honeycomb or a soap bubble appearance. And the cause is obviously due to a repetitive vasoconstriction or repetitive ischemia producing hypoxia. They have tried these drugs. Of course, it's related with tobacco. Now coming to the next condition, which mimics that isolated aortitis to a great extent, this is called as a middle aortic syndrome. What do we mean by this? That means the middle portion of the aorta is the one that is commonly involved. See, you can see the constriction here. So let's go about this disease. It can produce a segmental or a diffuse narrowing, and then it can affect the ascending, descending, abdominal and distal descending aorta. These are the areas that are involved. And it's very common in children, common cause of renovascular hypertension in children because it can affect the renal arteries and the visceral arteries also can occur. This is a congenital and a developmental anomaly, because there is a defect in the fusion and during the maturation phase of the dorsal arteries, the great arteries. So it produces stenosis and fibrosis over there. The location is mostly suprarenal and it's an extra aortic disease. Usually manifests with hypertension, and acquired causes can be due to Takayasu or post-surgery or radiation. Treatment for the hypertension, we see the treatment here, and for the antihypertensive statins also play a good role. And then, of course, we have to go for interventions like plasty and bypass. Coming to the last DD. This is fibromuscular dysplasia. All of us know about FMD. What is FMD? All of us know. Yeah, it's FMD. Yes. But do we know about the different types of FMD? What are the clinical manifestations you can produce? Why has it been mentioned in the criteria previously that you have to rule out FMD and atherosclerosis as the first two DDs? But I'm presenting it last because we know about this somewhat, but we have known more in detail. The age group again here is age 20 to 30 years with a female to male 3:1. And then see the manifestation. It mimics a large vessel vasculitis with headache, claudication, dizziness. All these can occur. Headache can occur in GCA and TAC. Claudication and dizziness can occur in Takayasu. But this is a non-inflammatory condition. What happens here? Here you have the renal arteries that are involved, the internal carotid. The locations are very important because you have to differentiate it from atherosclerosis also. And the segmental arterial mediolysis. So we spoke about the arterial distribution in SAM. Now we have to see the arterial distribution in FMD. So renal arteries, internal carotids, the intracerebral vessels. See, you have that's a renal artery, you have the string of bead appearance, and then you have the internal carotid artery here showing not very clear, but the CT angio has picked up coiling over there. And then you have the vertebral artery also that can get affected. And you have the mesenteric artery. And what is the classical appearance? Either it can be a string of bead, or it can be a focal concentric narrowing, or it can produce a diffuse tubular stenosis. Aneurysms can occur, dissection can occur. Renovascular hypertension is very, very common. Other important manifestations are TIA, CEA, myocardial infarction. It can affect the coronaries also. So almost all the medium-sized arteries can be affected. This is a diagrammatic representation. I just put it to show you the different myriad manifestations of FMD, starting from tinnitus, dizziness, headache, hypertension, carotid bruit, tinnitus. And then these are the arterial manifestations, a classical string of bead appearance. You may ask me, this also produces stenosis, and Takayasu also produces stenosis, but always remember, the stenosis is away from the origin. In Takayasu, it's just beyond the origin. All the arteries that are affected in Takayasu will be just beyond the origin. But here, it's all away from the origin, like whether it's the ICA or the vertebral or the coronaries or the renal, all of them, or the mesenteric, the stenosis will be away from the origin. The string of beads, a focal stenosis, when it goes in for dissection with a false lumen, then the aneurysm, and you see the tortuosity here. Coming to atherosclerosis, our final DD. So what are the sites? Again, see, what is very important is the sites. If you know the sites for different diseases, it becomes fairly easy for us to differentiate between all these. Of course, atherosclerosis, not that it occurs only in the old people. In long-standing vasculitis, atherosclerosis is going to be a complication. Even in the 20s, 30s, you're going to see atherosclerosis. So what are the sites for atherosclerotic involvement? Abdominal aorta, infrarenal artery, especially the bifurcation. Bifurcation usually doesn't get involved in Takayasu. And it doesn't get, the bifurcation as such doesn't get involved in GCA as well. So the ostia starting the beginning of the arteries, the ostia, especially the carotid bulb, upper limb arteries are spared. So it's usually the abdominal aorta, the bifurcation, and then it can occur in the carotids also. Aneurysms, narrowing in the branches. What is very important here is a rheumatological emergency, which can be a monoocular visual loss, like in GCA. But this is a non-arthritic ischemic optic neuritis. This is multifactorial. It may be a disrupted optic autoregulation or secondary to hypertension, diabetes, or it can produce a CRAO or a branch retinal artery occlusion due to the plaques, and it can affect the coronary artery, the renal artery, it can produce embolization. This is the ocular counterpart of the ischemic stroke. So we have to be very careful when the patient comes with blurring of vision, you suspect atherosclerosis, you know that there's going to be an impending stroke always. So how do the lesions appear? They can be punctate, they can be slightly linear lesions, they can be discrete plaque lesions, or they can be a localized hotspot, like you see in the PET scan. You see only hotspots in the PET scan, or a localized thickening of the intima media. We already discussed both in Takayasu and in GCA, you have an intima media thickness, but there that will be a uniform circumferential thickening, and it will be uniform. Whereas in atherosclerotic, it will be eccentric. These are the two walls, and then you have an eccentric plaque that will be occurring, obliterating the lumen. This is called as a slope sign. The slope sign is from a normal intima, it goes to gradually it goes to a thickened intima media in GCA and Takayasu. Whereas in atherosclerosis, from the normal intima, it will abruptly go into like a step ladder pattern or a step pattern. The slope will be very abrupt slope sign. This is called a slope sign in atherosclerosis. This is a one. See, here you see a very transient, very gradual slope occurring over there. Whereas in atherosclerosis, it will be a very abrupt one occurring. So this is called as a gradual to from normal to abnormal in vasculitis, whereas it's very abrupt in atherosclerosis. And with that, I think I will conclude. All large vessel involvement is not vasculitis. Takayasu and GCA have similarities and differences. Mimics are many. And they tell us, forget me not, like these cute blue flowers, little blue flowers. Thank you for your patient listening.
Thank you, ma'am. It was such a wonderful lecture. I think it was like a lot of excellent slides, that's first. A lot of good images, which gave us such a true picture of all the different, entities. So I wanted to ask a few questions. You have time, no, ma'am?
Yes, I have
Yeah.
time.
So when you have this isolated aortitis, like in giant cell arthritis, you said you can do a biopsy, and nowadays you have ultrasound also, which will help. But
Yes.
these other vasculitis, when you have middle aortic this or isolated aortitis, we can't really biopsy the parts. So once you've ruled out HIV or syphilis, tuberculosis, if we don't have anything to biopsy, we just do a Mantoux or TB
Quantiferon
gold,
gold.
quantiferon gold. Then how you go about diagnosing this isolated aortitis of the middle aorta?
That's
mean-
very, very difficult because that's why we have associated manifestations. Like you look for, I already told you, no, that it could be due to bloodstream spread or a lymph node spread. We have to hand them over to the radiologist for a percutaneous CT guided or something like that. But see, many a time, even the radiologists find it very difficult if it's close to the aorta. They'll say it's a very high risk case. Very few people take it up. So we go for other sites which are amenable for biopsy. And we try to get a biopsy. If not, we go ahead with indirect tests and imaging techniques, and provisionally we start them on treatment along with our other drugs. Just like how we treat lupus very aggressive severe flare of lupus associated with infection, we don't stop the treatment for lupus, aggressive treatment. We treat the infection alongside. The same thing holds good for vasculitis many a time. And we have succeeded. IgG4 and all is very easy to pick up. Very easy to pick up. This isolated iotitis, as you're telling, we can pick up actually with bold radiologists. But then they themselves have given in literature that you have to give a trial therapy of steroids or immunosuppressives after you've ruled out everything.
There's some questions in the chat box. What is the incidence of thrombosis and TAC in GCA?
Incidence of thrombosis is grossly more in Takayasu as opposed to GCA. In GCA, we have inflammation. The destruction is more, actually, it's more of an aneurysmal involvement rather than a stenosis. In Takayasu, because it's a very chronic, recurrent problem, relapsing problem, the incidence of thrombosis is very high. Not that we cannot get CVAs and GCA. With intracranial involvement, we do get, we have two varieties we know now, no? It's extracranial and intracranial. With the intracranial variety, we can get ischemic strokes also.
But usually it's the optic ischemic.
Yeah, that's a first rheumatological emergency which we encounter. And you never get to see the tongue claudication or the jaw claudication and all in Takayasu. They're very, very classical for GCA.
Yes. We usually see pulmonary aneurysms in Behçet.
Yes.
How often are mesenteric arteries and celiac axis involved in Behçet? How symptomatic would that be?
Our experience with Behçet, with mesenteric celiac aneurysms and all is quite limited. Maybe we have not really bothered to look into it, or maybe we had not been aware of it. But they do occur, and they can be asymptomatic, not as symptomatic as Takayasu actually for the infection. Some of these can remain asymptomatic unless they come to a major area like the pulmonary system or one of the cranial vessels or something like that. We have seen aneurysms in the forearm arteries, in the ulnar artery and in the radial artery in Behçet. So those are areas which are they're very symptomatic. If they lie close to symptomatic areas.
Dr. Varsha, you want to ask anything else? This was Dr. Varsha's question.
Yeah, no, ma'am. Just wanted to know. Thank you, ma'am, for a wonderful talk. I'm Dr. Varsha. I just want to know if you have celiac axis aneurysms, would you rather think of some mimic, or would you be thinking more of Behçet, especially if it's a little middle-aged male, no other features?
Our
maybe no
experience
eye
with celiac
involvement.
artery aneurysms is not at all good. If you ask me, celiac arteries are involved grossly in Takayasu.
Okay,
They
ma'am.
can be involved in Berger's disease, which I'm not highlighted, that comes under the medium vessel. They can be involved in aneurysms in celiac arteries, polyarteritis nodosa, yes.
Yes, ma'am.
That is very, very common and very symptomatic. Okay. Though very often we do a screening angio for PAN when we see a patient with ulcer and hypertension and constitutional symptoms. We usually pick up in the visceral arteries.
Yes.
But Behçet with celiac aneurysms, to my knowledge, I have not seen. I really have to look up into literature. Maybe I can get back to you all in the group.
Thank you so much, ma'am.
There's one. In FMD, how common is mesenteric ischemia?
Sorry, ma'am?
In FMD, how common is mesenteric ischemia?
SMVP? Small
FMD. If in fibromuscular dysplasia,
FMD. FMD? How common is?
Common is mesenteric ischemia.
We have not seen. We have seen renal arteries, we have seen carotid arteries, we have seen coronary, and we have seen brachial arteries. My experience with mesenteric is limited, ma'am.
Okay, it's actually a lot of questions on celiac artery only.
Yeah, I should read up. Maybe I can read up about the celiac artery.
Class on celiac. There's one more question by Dr. Aditi. We have come across a young male with isolated celiac artery involvement, mid-segment, nothing on imaging elsewhere. Inflammatory markers are normal. Can SAM involve celiac artery as well?
SAM means segmental arterial medial SAM.
Yes, medial, yeah.
Yes. We said no. It affects the visceral and renal arteries.
Visceral, yes. Yeah, actually, visceral artery involvement often is a therapeutic dilemma also. They come to the surgeon, then they refer to us, and we've got no clue. Like, main problem, should we immunosuppress them?
Anything away from the origin, I already told you. The location of the lesion is very, very important. Anything away from the origin, it may be an APLA, it may be an FMD, or it may be a SAM.
Mm-hmm.
Okay. So then it should instigate us to look into other areas as well.
And then how do you therapeutically, when you have something away from the origin? So therapeutic strategies, how do you plan
Therapeutic
that?
strategies depend upon the clinical manifestations. If you are manifesting with hypertension and other complications, you have to treat the symptoms and signs of coronary involvement or whatever it is, and the risk factors. Finally, they may have to go in for an intervention like a plasty or a bypass.
Yeah, immunosuppression, in which conditions you would be aggressive?
Only the inflammatory conditions. Why should we go in for immunosuppression in the non-inflammatory conditions? That's why in the classification itself, you mentioned, isn't it? Congenital and acquired. Non-inflammatory conditions are not going to get affected by any immunosuppressant.
Yeah, sometimes we don't know. Inflammatory markers are normal, and we're not able to decide.
That is why this lecture, for us
Yeah.
to try to differentiate the location of all these diseases and trying to work up for these diseases, and that we should not often miss and go on treating them. Like those years, aneurysms and all that, we used to think only of Takayasu and GCA. We never used to think of anything else. And maybe TB would come into the picture with the Bechet popping in here and there. That is all. But then we used to keep on treating them. Maybe they turned out to be the SAM or an FMD or which we left undiagnosed.
Yes.
It's very difficult. It's very difficult. Only experience can teach us.
Yes. Yeah.
Not even literature.
Okay. Anybody else? Any questions? Okay. Thank you, ma'am. It was an excellent lecture.
I can just give you one case report of a lady, middle-aged lady whom we had. And she came with hypertension and claudication symptoms. When we saw the angio, there was something like a dissection and ulcer over there in the aorta. And we thought maybe, okay, it's a dissection or she must be having Takayasu because the renal artery may be involved. And finally, but all the markers were, acute phase reactants were normal. And then the radiologist gives a second report saying that this is FMD in a 50. Like sometimes it's so difficult. Let's see, let's wait and see till we get more markers. And thank you all for the interaction.
Thank you so much. A lot of thank yous on the chat box for you. Excellent lecture, ma'am. Yeah, a lot of appreciation. Really great. Thankful to you for joining us.
I love this talk and really I enjoy when I'm with students.
Yeah.
And we all learn together.
Yes, ma'am. Thank you so much for joining us on a busy Sunday.
Sarita and MRA. I love today. I love this Sunday. Thank you.
Thank you. Thank you. Good day to you. Good day to you, ma'am. Yeah. Bye-bye.